So, welcome everyone to our fourth lecture in this series. Um, Today we are happy to have Dr. Abik Ray Chaudhury. He's head of the neuropathology unit here at the NIH. He was previously associate professor and the director of the Division of Neuropathology at the Ohio State University Medical Center. He graduated medical school in India and then did his pathology residency at Marshall University in West Virginia, then continued to fellowship in surgical pathology in University of Kentucky and neuropathology in University of Alabama. He provides the clinical neuropathology services and CNS autopsies at the NIH and involved in research projects, including neoplastic and non-neoplastic disorders. And he has extensive educational experience teaching neuropathology for students, residents, fellows, and is the author of several book chapters on the topic. And we are grateful for you joining us today. Let me stop share and then you can share your slides.
So do I go back to share screen?
Yes, please. That's perfect.
Can you see it now?
Yes.
All right. Should I go ahead or?
Yes, please do. Thanks.
All right. All right. Today's lecture will be limited to define and describe the main patterns of infections involving the CNS. So in pathology, we diagnose individual disorders in the brain and spinal cord, looking at tissue, and individual organisms and groups of organisms show different patterns in the tissue that we recognize. And when you see these patterns, it would be easier for you to recognize at least what group of organisms can cause this infection. To do that, we will go through a number of pictures that shows gross and microscopic pathology of the most common bacterial, viral, fungal, and parasitic infections of the brain. So what I'll do is, since time is limited, we will see a number of organisms from each group, and then I'll move from one group to the other. Like we'll see some bacterial elements and the patterns they produce, and then we'll move to viral, and then some important fungal elements, and then some important parasites that infect us. And at the end of it, we will know at least what groups, that these individual groups, they do have their individual footprints with which we can diagnose the disease rather easily. All right, so to start with, there is I thought that there are a lot of terminologies we use in CNS inflammation and infections, and I thought it would be good to know what these terminologies means. Like for pachymeningitis, it's a term we use for the inflammation of the pachymeninge. And by pachymeninge, we mean dura. Dura is the pachymeninge. And right under the dura, we have leptomeninge, which is arachnoid and pia. And we'll see examples of leptomeningitis to start with. Then encephalitis is a term that is used to define more diffuse inflammation of the brain parenchyma. It's not located in any one particular area, and usually caused by viral agents. And the main inflammatory cells we see here in encephalitis are chronic inflammatory cells like lymphocytes and macrophages. Cerebritis, on the other hand, is a very focal inflammation of the brain parenchyma as against encephalitis, which is a diffuse inflammation. And when we say cerebritis, we mean a focal inflammation where we see mostly neutrophils, acute inflammatory cells. Usually these are caused by bacterial agents. We need to know this. And cerebritis can be a focus on nidus for brain abscess and other disorders. Myelitis is inflammation of the spinal cord, and radiculitis is inflammation of the intradural spinal nerve roots. Sometimes we combine these terminologies, like when inflammation is present in more than one compartment, we call them like meningoencephalitis, myeloradiculitis, etc. Okay, so start with all the infecting organisms we consider. There are multiple channels through which they reach the brain and spinal cord. And there are 4 or 5 different ways they can reach the brain. Most common of them, as we all know, is through the blood, the hematogenous spread. That's the most common way an infecting organism reaches brain. Then the next common is local extension. Our nasopharynx, paranasal sinuses, otitis media in the ear. Lots of organisms, bacterial or fungal or protozoal, like the amoeba, they use this route to reach the brain. Retrograde transport from peripheral nervous system, rabies likes it very much, as we are going to see. From the muscle, they jump into the motor neuronal axons and go retrogradely to reach the spinal cord. And from the spinal cord, again, retrogradely, they go up to the brain. And from the brain, they spread to the lacrimal gland, salivary gland, etc. Direct implantation always happens through traumatic injury, surgical procedures, injections, etc. So these are the basic 4 channels through which organisms reach the CNS. Most common, again, is the hematogenous spread that we need to know. Radiological patterns also helps in recognizing certain compartmental involvement, like for pachymeningitis, any scan will show the enhancement of the dura. Leptomeningitis, on the other hand, will have enhancement involving the sulci because arachnoid and pia actually go deeper into the sulci. Infection that involve only the gray matter mostly, like the prion disease or rabies, etc., they will enhance in the gray matter of the brain. So radiological, the X-rays and scans do help us identifying the location of the disorder, and when we get the tissue, it helps us in diagnosing. So the first group of disease would be the bacterial meningitis. As we already saw that meningitis here is leptomeningitis, inflammation of the arachnoid, subarachnoid space, and CSF. The infecting organisms are also abundant in the CSF. So CSF analysis can be a very good way to diagnose bacterial meningitis. Can be divided into two groups, acute and chronic. The acute one we call pyogenic meningitis, which is caused by virulent bacteria. Chronic lesions are caused by tuberculosis. We see them even now in this country. Spirochetes like syphilis, which is very rare right now. Okay, so I don't see the whole screen though, because I need to move this. Hey, Warren.
Yes.
How can I move these? The names are on the bottom of my screen, so that is kind of covering the frame.
You should be able to minimize it.
Okay.
There should be a.
Oh, it's gone. Okay. All right. Sorry. Acute bacterial meningitis, it's a worldwide disease and mostly caused by virulent organisms like Streptopneumoniae, Neisseria meningitidis, and Haemophilus influenzae. These three cause almost 80% of the cases. But there is a age division of this meningitis according to the age of the patient. Like for newborn or neonates, 0 to 6 months, group B strep, E. coli, and Listeria monocytogenes are the most common. Listeria again is common in the older age group. Strep pneumonia is common in the children and adults as well as in the older adults. Grossly, the subarachnoid space is filled out with pus, purulent material, and that's very easily seen. Normally, the leptomeninge is transparent and you can see the surface of the brain. But in acute pyogenic meningitis, because of this opaque purulent material, the brain underneath cannot be seen. It's very easily diagnosed just looking at the gross. When we make sections of the brain, and here is a coronal section, and you can see the exudate is actually filling out the sulci. And here is the thin arachnoid membrane. And the sulci are filled with exudate. If you take a small bit of tissue and look under the lens with normal hematoxylin and eosin stain, you can see the meninges is greatly thickened and full of inflammatory cells, most of which are neutrophils. This is an acute infection. And if you take a closer view, the meninges are very thick with neutrophils, and sometime, not always, but sometime the inflammation can go deep through the Virchow-Robin space in the sulci and then laterally move into the brain to infect the brain parenchyma. When that happens, we can see something like small focus of acute inflammatory nidus or focus, and this we will call cerebritis. So leptomeningitis can spread into the brain, not very common, but it happens to produce cerebritis. That is a complication which is prognostically is not good. Likewise, CSF flows through the subarachnoid space. So through the CSF, it can involve the ventricles of the brain, and we'll call it ventriculitis. These are serious complications of the bacterial meningitis. And this is why if the treatment is not given early enough, this disease is usually fatal. As I said, CSF analysis for bacterial meningitis is very informative. almost diagnostic. And many of you know this, the pressure of CSF increases, and the WBC count, which is normally 0 to 5 lymphocytes, can be hundreds and thousands, most of which are neutrophils, 80% or more. Bacteria utilizes the glucose in the CSF actively, so the glucose can come down to 0 actually. And the protein increases manifold. So CSF is usually, one can make a smear and stain it. And in acute bacterial meningitis, the bacteria are abundant. So you can easily see with a gram stain, gram positive or gram negative bacteria. And then one can do a culture to specifically isolate exactly which organism, which bacteria is causing the infection. So next, this group of bacteria that causes the next infection would be, the next disorder would be brain abscess, which is a mass like lesion caused by bacteria. But for brain abscess, usually the bacteria are not very virulent. Unlike the leptomeningitis, the bacteria causing brain abscess are mostly less virulent organisms like the viridans group. Streptomylae is one of the very common organisms that moves to the brain from the dental infections. Mostly these bacteria come from sinusitis, middle ear infections, mastoiditis, dental infection, etc., and spread from there. However, abscess can be produced by bacteria that come through the blood into the brain. For these infected nodules in the heart, like rheumatic nodules in the heart valves, can be a nidus of these bacteria that can jump into the blood and go to the brain. And in the brain, the bacteria first establishes a small nidus of cerebritis. And if undetected, this will progress to become a full-fledged abscess. When abscess happens, radiologically, it shows like a lesion that we typically call ring or rim enhancing lesion. The center is necrotic, so it does not enhance with the dye, but the periphery enhances because it's full of blood vessels or capillaries that actively take up the dye. This ring enhancement is also a feature of high-grade brain tumors. So that's the differential between the brain abscess and a high-grade tumor like glioblastoma. They will look similar radiologically. However, if you do a biopsy, it's very easy to diagnose, differentiate between the tumor and the abscess. A typical abscess can produce a mass effect. Here, you see this abscess is actually producing a mass effect by compressing the third ventricle. And this side of the brain is inflamed and swelled, and an uncal herniation can happen. Brain abscess usually have a very solid wall. The center is full of necrotic material or purulent. The wall consists of a reddish granulation tissue that is full of capillaries and a mixture of acute and chronic inflammatory cells. So the center is necrotic, then a layer of granulation tissue, and in established abscess that takes weeks, when you start seeing a very thick fibrotic wall. And when that happens, it's difficult to treat because the antibiotics do not penetrate into the abscess very easily. So meningitis and brain abscess are usually caused by bacterial agents, one virulent, the other not so virulent. Chronic bacterial infections, tuberculosis, it's prevalent in immunodeficient patients, and AIDS is very common, and TB is AIDS defining disorder also. So TB happens with reactivation of dormant focus in the lungs and brain. So in our childhood, when we get infected, in the lungs we have Gons focus, and in the brain, small dormant focus foci are present that are called rich focus. When they are reactivated due to immunosuppression or otherwise, tuberculous bacteria usually causes meningoencephalitis. And that is small gray-white nodules in the meninges and in the brain. They can also cause a tumor-like mass called tuberculoma and a frank tuberculous abscess. And that's how they look grossly. This is the base of the brain. This is cerebellum, hardly recognizable. And this is the pons, medulla, and the brainstem, which is covered with thick, cheesy material. For this, the term caseous necrosis was coined because it looks cheesy. It's a grossly identifiable term. Base of the brain, TB, for some reason, they prefer base of the brain more. Tuberculoma as the name suggests, is a mass-like lesion. Can happen in the base of the brain, or here in this case, it's in the cerebellum. But whatever it is, wherever is the location, it could be in the meninges like here, or in the parenchyma, like a tuberculoma. If we take the tissue and stain it with normal H&E stain, what we are going to see is a pattern called granuloma. Granulomas are nothing but a combination of lymphocytes and histiocytes. Many of these histiocytes combine to make multinucleated giant cells called Langhans giant cells. And this is very diagnostic of tuberculosis, tuberculous granuloma. Neutrophils are not usually seen in these lesions. And when you do acid-fast stain, as for acute bacteria, we did gram stain, but for chronic, if we see granuloma, we employ the acid-fast stain that will show the acid-fast organisms, the tuberculous, Mycobacterium tuberculosis, very nicely. They are pink rods. And they usually reside in the necrotic areas rather than in the periphery of the lesion. CSF again can play a role to diagnose. Unlike the acute bacterial meningitis, the pressure is not that, it's increased, but the leukocyte count is not greatly increased, and they are mostly lymphocytes, not neutrophils. Glucose is reduced, but not as much as in the bacterial meningitis. Diagnostic testing for bacterial infection as a whole, we do analysis of the CSF, as we saw, then culture of the CSF, and we do smear and staining. For some bacteria, like Haemophilus influenzae, strep pneumoniae, etc., identification of the bacterial antigen through latex agglutination test is also very successful. PCR analysis has increased the diagnostic yield very much nowadays. This recognizes the bacterial genetic material especially in case of tuberculosis, the number of bacteria in the CSF usually is very low. They're not high. So the yield for culture, and culture is also takes a long time. So PCR helps identifying tuberculous meningitis very nicely. Recently, the new generation sequencing, or NGX, for identification of genetic material is also gaining ground, and will have a presence in the future years. So much for bacterial infections. See, if there is any question, you can ask me. Okay, I'll just move to the viral. We're going to look at some important viral agents. Usually produces encephalitis. Aseptic meningitis is also produced by virus, can be produced by bacterial agents. These are usually self-limited disease and does not cause much fatality at all. Enterovirus are mostly accountable for these. Polioencephalitis is a term we apply to the virus that involve mostly the gray matter of the brain. Of course, poliovirus is one, but rabies, they involve the gray matter specifically too. Panencephalitis, on the other hand, is diffuse inflammation of the brain, and herpes simplex virus or HIV are among the most important ones. Leukoencephalitis, on the other hand, inflammation of the white matter. And JC virus, causing progressive multifocal leukoencephalopathy, is the most important virus nowadays that is restricted to the white matter, causing demyelinating disorder. HIV can produce typical leukoencephalopathy too. The virus can enter brain through various ways. Herpes simplex virus can be dormant in the olfactory bulb, and from there they can gain entry into the brain. Rabies, as we saw from the periphery, they move to the spinal cord through the retrograde transmission of motor axons, and from there they can climb up to the cord into the brain. Virus can use the Trojan horse phenomenon, that is, from the peripheral dormant sites, they gain entry into the monocyte or macrophage, and when the cell enters into the brain, they creep through the blood-brain barrier and get out into the brain parenchyma. This cartoon is just to show that the compartments the individual viruses use. The JC virus likes the white matter. Rabies involves the cerebellar gray matter, as well as the Ammon's horn or the brainstem, but they involve the gray matter mostly. Herpes simplex loves the temporal lobes and frontal lobe. We do not know exactly why, but they have a predilection for these areas. Prion disease, though it's not a viral disease, they also are very much restricted to the gray matter of the brain. Encephalitis, usually, no matter what virus causes it, they all look similar grossly and mostly microscopically also. Grossly, the brain is usually swollen. It's a diffuse inflammation. There can be petechial hemorrhages here and there. Here, just looking at this gross, we can think of herpes virus because it is involving bilateral temporal lobes. But microscopically, when you have the tissue, there are three patterns that one needs to identify to diagnose encephalitis. And when you know that, it would be easier for you at least to bring down the diagnosis to an encephalitis from other infections. So the first of these three is presence of thick cuffing of blood vessel by lymphocytes. These lymphocytes are laden with virus though. You can do immunohistochemistry for individual virus and they will light up the area. So perivascular lymphocytosis, as we call them. The second pattern is the microglia in the brain becomes active and they try to control and the virus in areas of the brain, and that's how these microglial nodules are produced. They actively scavenge the virus also. So microglial nodules, and then the other phenomenon is interesting. It is, if you look at the gray matter, you will see that the degenerating neurons are surrounded by these activated microglia. And what they will do is they will scavenge the neuron because it's filled out with the virus particles. It's a phenomenon we call neuronophagia, or eating up of the neuron. So even if we do not have a clinical information, if you get some tissue from the brain and you are seeing perivascular lymphocytosis, scattered microglial nodules, in the gray matter here and there, some neuronophagia, you can safely diagnose an encephalitic process. No other organism will produce this. So beyond that, individual virus that produce encephalitis also leave their mark, like herpes simplex and CMV, they will produce inclusion bodies, which are collections of millions of virus particles in the nuclei. We call Chaudhury A type inclusions. Cytomegalovirus, the same thing. Progressive multifocal leukoencephalopathy caused by JC virus is little different. They will produce nuclear inclusion. However, they infect specifically the oligodendrocytes. It's a glial cell, not the neurons like in the CMV or herpes virus. They infect the astrocytes and oligodendrocytes and kill the oligodendrocytes and thereby produce the demyelinating lesions because oligodendrocytes produce myelin. Rabies, on the other hand, it's a single-stranded RNA virus, and the inclusion is seen in the cytoplasm, not in the nucleus. Actually, this is the only prominent virus that will produce Negri bodies or Lisa bodies in the cytoplasm, not in the nucleus. Usually we diagnose viral infections through lumbar puncture and CSF analysis. Virus culture is also possible, but again, polymerase chain reaction can identify viral nucleic acids pretty quickly. Neuroimaging really helps because that can easily take out the differential diagnosis of tumor, abscess, and other non-viral processes. Herpes and encephalitis, as we saw before, they love the temporal lobe, and here the bilateral temporal lobe is involved with very aggressive hemorrhagic encephalitis. They lie dormant in the trigeminal ganglion and olfactory bulbs, and when reactivation happens, they invade the brain and cause the again, the diagnosis at early stage is very important because there are effective treatment, but delayed diagnosis can lead to fatality. So here, how the Chaudhury inclusions look like. You can see the neurons are kind of shrunken now, smaller, and their nuclei are expanded with very smudgy eosinophilic inclusion. If this is a normal neuron on the left-hand frame, the cytoplasm is basophilic, but in the shrunken neuron, you can hardly see any cytoplasm, and the basophilic nucleus has become very eosinophilic with the viral inclusions. Rabies, in the US, dogs are not the main cause of the disease because dogs are inoculated or vaccinated. But in the rest of the world, in the developing world, dogs remain as the main source of the disease. In the Western world, though, bats, skunks, and raccoons are the most reservoirs. I'm moving a little faster so that I can finish up before the time. Rabies, as I said before, involves mostly gray matter, like the Purkinje cells in the cerebellum. So these are the internal granular cells, and the big neurons of the Purkinje layer, they show the rabies inclusions, which are negri bodies. And if the inclusions are not very well demarcated, it's called Lisa bodies. And they are very nicely seen in a stained slide. Rabies can also involve the pyramidal neurons of the Ammons horn in the temporal lobe. Very important disorder is PML because of large number of patients who become immunodeficient nowadays because of AIDS and many other causes. Jesse virus that lives as a dormant fossa in our kidneys and lymphoid tissue, when we become immunodeficient, they get into the blood, move to the brain, and produces the disease. They're usually fatal, especially in case of AIDS. The secondary infections are usually fatal in few weeks. If it's non-AIDS patient, then it can take a longer, but they are also usually fatal. The disease is limited to the white matter because, as I said, they love oligodendrocytes and they usually destroy the oligodendrocytes, producing typical white matter necrotic patches. If you look at this slice, the gray matter looks fine. But looking at the white matter, which should be like this normal, here it's very granular and crumbling because it's necrotic. If you look at this, you can recognize that this disease is involving the white matter. And when you pick up a small bit of tissue and stain it with loxolfast blue, which is a stain for the myelin, you can see these small circumscribed zones of demyelination. This blue color is the normal color of the myelin, and the color is gone. Why? Because the oligodendrocytes are being killed by the virus. And if you stain this tissue with just standard hematoxylin and eosin, one can easily see the oligodendrocytes, which are a small normal oligodendrocyte is of this size, but it becomes very large now that it's laden with millions of virus particles, and the nucleus is very smudgy because that's the inclusion. So inclusions in the oligodendrocytes in the white matter, that's almost diagnostic of PML, even in routine stain. We do not need any other special stains, but we still do. One can do an immunostain called SV40, which is simian vacuolating virus, a similar virus like the JC, and they share antigens. So when we employ this immunostain, all the oligodendrocytes laden with virus particles will light up as brown cells. And that's diagnostic. JC virus also infects the astrocytes. They do not usually kill them, astrocytes become very big and angry looking. And when the number increases, the area can look like an astrocytoma, a tumor actually. And pathologists have made wrong diagnosis of astrocytomas because it's very deceiving. If you get a tissue where most of these astrocytes are, it does look like neoplastic. The next viral disease is HIV, very important disorder. HIV usually produces encephalitis and 2 other disorders in the brain. The brain as such grossly may appear normal, or if it's in advanced stage, the brain can appear atrophic, especially if the patient is demented. And it's an encephalitis. So usually, as we saw before, you see low-grade inflammation in the brain with microglial nodule and perivascular lymphocytic coughing as usual. But HIV is very significant because HIV produces, in addition to those 3 patterns, it produces scattered large multinucleated giant cells. And if you do immunostain for AIDS glycoprotein 41 antibodies, they will light up. Other than encephalitis, AIDS can also produce a necrotizing leukoencephalopathy that is restricted mostly into the white matter. It is rare. And lesion is like high HIV load with intense perivascular macrophage and lymphocytic infiltration. This is a rare condition and has been described in patients who are receiving the CART therapy, the combination antiretroviral therapy, and they occasionally show this specific white matter involvement. The third condition produced by the HIV virus is called vacuolar myelopathy. Vacuolar because the areas involved are the white matter of the posterior column and the lateral column, something like the subacute combined degeneration caused by vitamin B12. But if you look at the tissue, it's full of vacuoles and large macrophages that are present, in which you can isolate the viral particles. So for HIV, we have typical encephalitis, leukoencephalopathy, and spinal cord vacuolar myelopathy. Other than that, HIV is known to produce certain dementing conditions. Nowadays, these are called HIV-associated neurocognitive disorder, or HAND, of which there are 2 or 3 different kind of disorders. Most serious is the HIV-associated dementia, or HAD. Histopathological correlate, we do not have anything specific for these conditions. Usually you see encephalitis or leukoencephalopathy along with it, but not always. The other interesting phenomenon with AIDS is that people who are receiving the antiretroviral therapy can sometimes show unexpected worsening of the disease condition. Though the overall parameters, hematological parameters are improving, the patient condition worsens. And this represents an hyperinflammatory and edematous flare due to improved host immune reaction. And in this case, CD8 positive cytotoxic cells, they actively invade the brain and breach the blood-brain barrier and produces perivascular inflammation mostly. That produces this serious situation. So much for the viral inflammations, mostly encephalitis, and we saw the different patterns of inflammation that's produced by viruses. PML produces typical inclusion in the oligodendrocytes, and the other viruses produces nuclear inclusion in the gray matter. Now jumping into some fungal infections. Usually fungal elements cause leptomeningitis or meningoencephalitis. Sometimes they can cause granulomatous abscess. And we are going to see some 3 or 4 important fungal elements that involve us. Usually there are underlying conditions for the fungal infections, like Aspergillus or Candida, they like neutropenic states. Lymphoma or leukemia, the other underlying conditions where we see more fungal infections. HIV/AIDS, of course, Cryptococcus and other fungus, they proliferate in this situation. Solid organ transplant recipients, diabetes mellitus, Mucorrhizopus group of fungus, love that. Aspergillus is very common worldwide. And usually they're hematogenous. They reach the brain from pulmonary and other foci through the blood. And when they reach the brain, they break down the blood vessel wall and produce hemorrhagic necrotizing lesions in them. And they're diagnosed by simple staining we call GMS or Grocott's methenamine silver stain. Aspergillus is a filamentous fungus. We need to know that. They are not yeast like the Cryptococcus. They're filamentous fungus. They are like threads or tape-like, and they are also septate. So you can see septi inside the filaments very clearly. So septated filamentous fungus, and they do have what we call acute angle branching, like 45-degree branching kind of proliferation. Zygomycosis or mucormycosis, on the other hand, these are filamentous fungus too. But if you look at the histology here, they are empty tube-like structures. They are not septated. And their branching is more obtuse, like 90-degree. Though we do not rely much on this branching, what we rely is on the presence of septi or whether the fungus is non-septate. Mucor is usually far more thicker than the Aspergillus. They invade patients with diabetic ketoacidosis more often. And this is a rhinocerebral disease because they come through the nasopharynx, pierces the cribriform plate, and invade the base of the brain, come through blood vessels, and produces significantly hemorrhagic lesions in the base of the brain and adjacent orbit. They usually has a tendency to move to the orbit from the base of the brain. They're usually fatal. Cryptococcus, on the other hand, is a true yeast. And by that, I mean they are not filamentous at all. They are AIDS defining disorder. Most common mycosis in the AIDS, they have a very thick capsule which is rich with myxoid material. And that's why when they go into the brain parenchyma, they produce very sticky, bubbly, soap bubble-like lesions. The meningitis that they produce is not as thick as that of acute pyogenic meningitis. It's kind of thin, purulent material. But and they produce granuloma-like lesion in the meninges too, with multinucleated giant cells and lymphocytes and histiocytes. Recognizing them is pretty straightforward. If you get some CSF or tissue and stain it with India ink, the India ink does not stain the organism. It's a negative staining, and you can see the large yeast-like organism, round, and you can see the thick capsule very nicely, full of mucopolysaccharide. And they are true yeast, and they proliferate by budding. You can see this particular one is having a bud. And the silver stain is the same. The Grocot's methenamine silver stain that identifies the aspergillus and mucor will identify Cryptococcus very nicely. Skip that. For fungal infection, similarly, we can have fixed tissue with histology, and you can do the specific fungal stain, and then the silver stain that will bring out the organisms. Serological testing or CSF detection is very successful in case of cryptococcal antigen. We can identify the cryptococcal antigen quickly in the CSF as well as in the blood. As for other organisms, PCR testing has become the gold standard nowadays. I have about 5 minutes, right?
Yeah.
So do I stop now or should I?
No, I think it would be great to see the parasites.
Okay, I'll just quickly continue just to show you the organism and some patterns.
Yeah.
Parasitic infections, very important is amoebic infections, cysticercus, and toxoplasmosis. Free-living amoeba, usually these are fulminant fatal disease, and two species are important. The first one is Naegleria fowleri, which causes primary amoebic encephalitis. And we acquire them usually from freshwater reservoirs like ponds and lakes, swimming into it. And that's why you may see some caution outside certain lakes, cautioning you for this particular disease. They go through the nasopharynx, causes cerebral swelling and hemorrhagic necrosis, just like the mucor in the frontal lobes and in the olfactory bulbs. Diagnosing them is relatively easier if you have the tissue and if you just stain it with routine stains. Free-living amoeba are 15 to 20 micron, the Naegleria, and they look like macrophages, but the difference is they do have a very prominent nucleus and central prominent nucleolus. And with these and the large size of them, it can be diagnosed rather easily. The other species is Acanthamoeba or Balamutria species that causes a different, little bit less fulminant disease, nevertheless equally fatal, that is called granulomatous amoebic encephalitis. So Acanthamoeba species, they not only involve brain, interestingly, they also go to the eye, and in the cornea, they produce Acanthamoeba keratitis, which is not very, if you are working in an ophthalmology department, you will see this Acanthamoeba keratitis every now and then. That happens. The organism is similar to Naegleria. However, they are far bigger than Naegleria. They look like big macrophages, and they produce hemorrhagic infarctions in the brain. In the eye, though, in cornea, they are more chronic disorder, corneal keratitis. That's what they produce. And if you do specific stains like GIMSA, you can see the organisms nicely present as round to ovoid bodies. Toxoplasma is, on the other hand, they are opportunistic intercellular organisms. Cats, domestic cats are usual definitive host, and we gain these organisms many times from the pet cats. When humans get infected, the organism lies dormant. However, they come out of their cystic state in the brain if we become immunodeficient. Normally, in normal population, there is 15 to 40% seropositivity, and they can cause congenital infection also, one of the torch syndromes. Immunosuppressed patients can have toxoplasmosis, which is necrotizing encephalitis. For some reason, toxoplasma likes basal ganglia more than other regions, and they produce ring-enhancing lesions also, just like brain abscess, but they're more necrotizing in nature, usually. In the tissue, toxoplasma are very small, tiny, 2 to 4 micron stellate or elongated organisms. In fulminant infections, they are very easily seen because they are present in hundreds, if not thousands. They are also intracellular. You can see them within macrophages in the brain. Along with the tachyzoids or trophozoites, one can see larger bradyzoid, larger cysts. That's the dormant form, which are full of bradyzoids, which are not infecting. They are the dormant state of the organism. And in an immunocompromised patient, these bradyzoids come out and become trophozoites and invade the brain. Tinea solium is very important because it's happening throughout the globe. And in this country also, we see Tinea solium now and then. This is a tapeworm that we get by eating cysts present in ham. Most common CNS parasite worldwide. There is no association with immunosuppression. And the interesting thing about Cystosarcus is that normally pigs are the definitive host. They have the cyst in their muscle that we eat. We are the intermediate host, and we should not have the cyst in our system. However, in an accidental route is that when we happen to ingest a large bolus of this larvae or the eggs of Cystosarcus, the larvae is hatched in the GI system, gain access into the blood, go to the different system of the body, including the brain, and produces cysts. That's not the normal cycle of the organism, though. It's an accidental cycle. When that happens, the brain harbors maybe small, but maybe large number of encysted Cystosarcus. Looks like this. Here, the cyst is residing in the meninges. You can see the arachnoid here, and the brain is right there, and the cyst is kind of floating in the meninges, subarachnoid space. In the brain, they can produce large number of cystic structures. And in radiology, they can be seen, almost diagnosed, because the scolex of the organism, the head, enhances, and you can see this central enhancing scolex of the cysticercus. When the patient becomes symptomatic, these cysts can be taken out surgically. But most of the time, the symptoms appear when the cyst dies and the cysts become calcified. The symptoms are produced, and surgically the cyst is removed. So what we see normally is not a nice scolex like that. They are usually not present in the surgical material. What we see is the wall, which is very diagnostic. This wall has 3 layers, and the layers can be diagnosed, which is very specific to the cysticercus cyst and can be diagnosed very nicely. I think.
Yeah, I think we can stop here.
Okay.
Thank you so much. It was a great review.
Oh, thank you.
I guess we can address one quick question. If you can give some quick points of COVID, on COVID neuropathology, have you seen any cases, or what's your impression?
Yeah, very pertinent question. We started doing COVID autopsy here in NIH, and several have been done already. Personally, I have reviewed about two cases of COVID. One case revealed acute stroke-like pathology diffusely in the brain. However, this particular patient had a myocardial arrest sometime before he was brought to the hospital. And myocardial arrest can produce acute stroke-like situation in the brain. Though in this case, I do not know whether it's caused by the cardiac arrest or COVID has something to do with it.
Mm-hmm.
Other than that, mostly I saw capillary congestion in the brain and in the leptomeninges. One of the cases showed some organized thrombus in the leptomeningeal vessel. But other than that, I'm yet to see any definite pathology. Now we are doing some special stains, and I'm also giving the case to other neuropathologists here. And what we have decided is that all of us will review so that we do not miss anything. So right now I did not put those pictures because it's too early. There will be some more time before we can we can come to a conclusion as to exactly what COVID is producing.
Of course. Thank you. Okay, so I think we'll finish with that. Thank you again, and thanks everyone. See you in 2 weeks.
All right. Thanks.
Thank you.